Welcome to the Palliative Care Map Care Review. So this care map here, we created a couple years ago, and it's now in effect that we can provide palliative care throughout our zone. So with this care map, just shown right here, we're currently still only using it in the East Zone right now. We are expanding to the rest of the province. We have been training Fisher EMS and also West Zone on teaching and using this care map here. So we are slowly getting provincial spread of this as part of our regular practice in EMS. The idea of this care map, when we created it, we had a lot of input from different groups, such as Office of Medical Director, Pharmacy, Palliative Care, Home Care, Palliative Care nurses, dispatch, like a lot of different people involved here to try and determine what would be best for these patients. Because a lot of times with palliative care patients, we have patients that don't want to leave their home. And honestly, a lot of times we don't want to transport them. And realistically, the hospital really doesn't want them either because they're kind of at end of life. So we were trying to figure what's the best way to make it happen that we can meet these patients' wishes as best we can. 9 times out of 10 is that they want to stay home, and we want to help facilitate that for these patients. So to activate this care map here, so when we can actually use it in the field, the patient has to be enrolled in the IRHA palliative care program, regardless of where they come from. This has caused a few issues at times, I'm not going to lie, because we're in the Interlake. We have a lot of lakes. People come out to their cabin for their last few days. It's peaceful. They like it out here. So we do have patients that come out here from WRHA, maybe Northern RHA. And unfortunately, we can't use this care map unless they're registered within the IRHA. So if you have a patient that is registered within the Winnipeg Regional Health Authority, there's a couple of exceptions we'll talk about later with transport, but we can't activate this care map unless they're registered within the IRHA palliative care. So the question is, how do we recognize if they're registered with the IRHA? So each of these patients on their fridge, they should have this decal. So this would give them, as you can see there, it says patient name and special patient program registration. So these patients should have a SPP number. This should be given to 911 when they call for us as well, so we know that we are going to a palliative care patient. So the other things that are really useful for us with this here is not only does it give us their registration number, so we know they're registered in the program. It tells you where their ERIC package is, which is something we really ramped up with palliative care patients for this program as well, because a lot of times we get there, it's like there's no paperwork. So we want to make sure that the paperwork is available to paramedics as well, so we can provide the best care that the patient wants or requires. So with that, we added that on this decal here, and their in-home chart as well. So when it comes to actual care for these patients, on average, the palliative care program in the IRHA is about 100 to 120 palliative care patients. And with that, they only have about 4 nurses, and one of them just retired. So they don't have a lot of resources. So unfortunately, when we were originally teaching this, we were talking about where the home chart is, things like that. But now just putting this into practice, we've had a lot of paramedics go to houses and they're like, we can't find paperwork anywhere. So what usually happens is, after just talking with the palliative care team recently, is that they'll make sure their patient has their SPP number so we can identify them as part of the program. We had one where a patient actually just got a text picture of this decal to give to show it to EMS when we got on scene, and that's all they had for documentation. So unfortunately, we may not always have the paperwork there for us, but they should at least have that SPP number and proof of that. And if they do, we can access our care map. So as much as we'd like to say the paperwork's all there for you, it may not be. Sometimes it may just be that ERIC kit. We may not have an actual home chart. If they do have a home chart, it's supposed to be centralized in the house. And if you can't find it, check on the decal here or talk to the patient or family members where their in-home chart could be. Another thing patient might have to identify themselves as part of the palliative care program is they may have a pocket card. So if the patient's not in their actual residence, they may have this on their person. So it's got the same information there. So it's got their name and where their ERIC package is and their home chart. And it also talks about, on the other side, it's got where their SPP number is, so we can identify that they're registered in the program. So like I said before, patients are informed to let dispatch know when they call 911 that they're with the program and give them that number. Sometimes dispatch will ask us over the radio if we want that number. It's up to you if you want to take it. Just remember that when you're doing your PCRs, you need to put that SPP number at the top of your PCR so we can identify that they are actually registered in the program. That's kind of important for not only just for showing what care you gave to the patient, and it makes sense because they're palliative, but also just for stats, because we're keeping track of this program and what we're doing and how we're helping palliative care so we can keep this program going. So another thing as well is when patients call dispatch or they call 911 for assistance. At first, when we talked with dispatch, they want to make all palliative care patients priority 5, which we kind of disagreed with because just because they're palliative doesn't mean they can't have crisis. Doesn't mean they can't still, not fall down the stairs and hurt themselves, things like that. So you may get called out to like a priority 1 palliative care patient based on what dispatch has triaged them as. So not every patient that's palliative will always be a priority 5. So don't be surprised if you get a priority 2 palliative care patient based on what's described to 911 over the phone. So reasons we don't use this care map for a palliative care patient is if it's an unexpected cause, such as an accident, suicide attempt, or assault. So like geriatric abuse is unfortunately a real thing. If they've had an accident, like I said, if they've tripped and fall down the stairs, or even they tripped on the rug and they broke their hip, that's going to be treated like a regular call. We're not going to start using palliative care measures for that because it's not part of their palliative care condition. It's a completely different event. The other one in here as well is suicide attempts. So these patients may be at end of life, and if they are dying because of their disease, then we can access this care map. But if they actively attempt to end their life, such as like slitting their wrists, we're going to treat it like a regular trauma, and we're going to access our regular care maps. We're not going to use this one here. Another reason we don't use this care map is patients' current goals of care include resuscitative measures. So if they do not have a DNR in place, we're not going to access this care map because this care map allows us to give medications for different reasons, for different things that we would normally do as per all of our other medication profiles. So an example would be like giving midazolam for massive hemorrhage, which we'll talk about later. Like we would never do that for a regular trauma patient. So if they don't have a DNR, we have to treat them with our regular care maps. And for the purposes of care map, the true allergy medication is the only absolute contraindication to giving medications. So another thing we came up with this program was how do we help people stay at home? One is medication admin. We don't want to be driving someone an hour down the highway just so they can get some pain control and then drive them an hour back. It's not really beneficial for anybody involved, especially if they sit in the hallway for 2 hours in between and they just need their med injected into their subcut line. So with this, we kind of made an exception, and this was along with talking with the medical directors, is that if the patient has medications at home, you're able to access the home care chart, you're able to see what the prescription, dosing, everything like that is, we can give the medication. So with that, again, if the patient wants us to not transport, that's the way we can help them out. So you don't necessarily have to be 100% familiar with the medication. Definitely talk to the family and the patient about what the medication is for, things like that. But at the end of the day, if it's a med you've never heard of and it's not in any of our scope of practice, scope of work, you are still allowed to administer it to this patient. So if you are concerned, if you're like, I don't know what this med is, this seems really sketchy, I'm not comfortable giving it, you can always call Online Medical, and that they put that in as part of their input into this as well, where we can give these meds so we don't have to transport. But if you're still not comfortable giving something outside your scope, which is not necessarily a bad thing, you can always call Online Medical for backup and understanding of what you're giving this patient. So the actual care map itself, so we're going to approach these calls a little differently. So we're not going to go in doing LOC, ABCs, vital signs. Sometimes we're going to start these calls with, what's your care plan? What did you call us for? What are you looking for with assistance? Because sometimes it's not necessarily they need us to deal with an emergency. A lot of times people just need emotional support because bad things are happening to their loved ones, and it's just their disease progress. We're not going to fix these people either. As much as we hate to say it, these patients are end of life. We're not going to save them. We're not going to fix them. They kind of know where they're ending up here. Everybody dies eventually, and these people know it. So when we go in, we're going to talk about goals of care, like why did they call 911? Again, if it's because of something completely non-related to their palliative state, we're going to treat it like a normal call. But if it's because it's end of life care, we're going to access this care map, and we're going to have that conversation with the patient and caregivers of what they would like us to do. So ideally in their home chart, there should be advanced care plans, things like that in place that we can reference for what the patient wishes and family wishes are for this patient. So one of the documents we may see here is palliative care, is the Healthcare Directive for palliative care patients. So this healthcare directive can be used by healthcare providers to determine what care is to be given to a patient if they're not able to state their own wants, needs for care. So part of it here is designation of a healthcare proxy. So this is a very important part of the healthcare directive, is the designation of a healthcare proxy. So in Manitoba, it's the healthcare proxy is a person that's able to make care decisions. A lot of times on TV, people say power of attorney, stuff like that. That's not a thing in Manitoba. Power of attorney in Manitoba means financial. So like they'll be running the finances for the patient's home, payments for payment for whatever they need day to day. But they don't have any say in medical care if they're power of attorney. So if you arrive on scene and someone's yelling, I'm power of attorney, I'm power of attorney, well, that's great, but we're dealing with medical, not what their bills are. So they don't really have much say in regards to healthcare. Definitely don't dismiss them. Talk to the families, see what they have to say. But at the end of the day, if they have power of attorney, that doesn't give them any ability to override this healthcare directive. So with this, so when we look at the proxies are chosen by the patient of who they want to represent them if they're unable to express their wishes due to disease process or they're just where the state they're in. So it's very possible as paramedics, we may have disagreements with the proxies. So as you can see here, there's proxy 1, proxy 2. Proxies are allowed to make changes to this verbally, and that's legal if they're on here, because again, the patient put them in charge of their healthcare if they weren't able to express their own wishes anymore. And like I was saying, with that, we may not agree with all their decisions all the time. It's not our job to say yes, no, but it is our job to make sure we're being good advocates for our patients and having conversations with the family of what would be best for the patient. Is this what you think they would want? We kind of try to steer them towards what the patient would wish because they're in crisis, right? They're watching their loved one die. They may not be thinking straight. They might be saying, go to the hospital. I don't care. Just go to the hospital. And it's like, just let you know the hospital's not going to do anything for this. This is what's going to happen if we go to the hospital. We could also tell them they could die in transport. They can end up dying alone in the ER. Like, I don't want you to scare them, but be realistic with the expectations of what the hospital may want to do. And we want to just let them know, like, this is what's going to happen. This is what we can and can't do. And at the end of the day, though, they make the call. If they want us to transport, we transport. If they don't want us to transport, then we see what we can do to help them stay at home. At the end of the day, the proxy has the final say. If they say transport, we have to we have to recognize that. So if you have a disagreement between your proxy 1 and proxy 2, sometimes it can be difficult making those decisions. But if you look underneath proxy 1, proxy 2, it talks about decision making. So it talks about if they're to make decisions, if there's more than one proxy present. So if proxy 1 is present, great. And proxy 2 is not there, proxy 1 makes the decisions. If proxy 2 is there, proxy 1's not, proxy 2 gets to make the decision. But if they're both there, we can have some disagreements. So if proxies aren't agreeing with each other on what kind of care they want to give, it says consecutively or jointly for decision making. So if it says they can make decisions consecutively, it means proxy 1 can override proxy 2. If it says jointly, it means that proxy 1 and proxy 2 have to agree on what they want to do with this patient or what therapy this patient needs. So again, that's where the facilitation of conversation comes in, where we don't really throw in our 2 cents of, no, they need to stay home, don't take them to the hospital. Like, don't be as blunt, but like, again, give them all their options, tell them what can happen, tell them, like, do you really, if we transport this patient, they may die en route to the hospital. That's a reality. Like be honest with them, but don't scare them either. So we can help them make that decision, and we can help facilitate that conversation between the proxies. If there are decisions the patient does not want the proxy to be able to change, such as like a DNR, it will be listed at the bottom here. So on the other part of the form here, so part 2, so under treatment instructions, if it's specifically wished by the patient, such as DNR, they do not want intubation, things like that, no chest compressions, but ventilations are okay, it should be listed under part 2. It may also say see other document, because as you can tell, it's not a lot of space to write down how you want to be treated at the end of life. So a lot of times it's left blank, and people say this is a DNR. It's not really. If it's not documented and signed, it's not a DNR. So it has to be written in there. And in part 3, it has to be signed. So for a DNR to be legal, it has to be signed by the patient. If that's what the patient requested in part 2, and it must be signed by a patient or a substitute as listed in part 3. So that's how we deal with making decisions on scene if other healthcare providers or if their family members have proxy status. So when it comes to advanced care planning goals of care, so this is another very familiar document. You've probably seen this quite a few times when we do transfers. We've had a lot of issues with the STARTS program with this sheet because it's really a bad sheet to be using. So all I'm going to say, we're going to go over it, but all I'm going to say is if you do an IFT with this sheet, it does not count if the patient has not signed it. If you just get a blank sheet with patient demographics at the top and they've checked off C and they said, here's your paperwork, it's not a legit document. So like honestly, I've done so many IFTs with these and they've only photocopied one side, they didn't photocopy the other side. Like it's a 2-page document. So make sure that you have this document completed entirely because we've had a lot of issues with this form. We did contact IRHA higher ups about this, and they got really upset because we were stirring the pot a lot, saying this is a completely not being done properly. So they're aware of it. I don't think it's changed anything, but we were trying. So when it comes to advanced care planning goals of care, at the top of the form, it's got all your patient demographics there. And it also says, is there existing healthcare directive? So if you're in a home and this is the first sheet you get, you also want to copy the healthcare directive. If you're doing an IFT for this patient, you want to copy that as well. So if they just give you this one side photocopy and said, there you go, that's all the paperwork and existing healthcare directives checked off, we need the documentation for that as well. So with this here, it breaks it down into comfort care, medical care, resuscitation. And I know before we started doing this program, I always had a lot of questions. It's like, okay, well, what's comfort care? What's medical care? Like, what specifically are we allowed to do? What aren't we allowed to do? So with the checkboxes here, it talks about comfort care. So comfort care, that would involve giving things like medications for pain and suffering because we want them to be comfortable. So comfort care doesn't mean they just get an extra pillow. It means like we can still do medical interventions, but it's just to make them comfortable at end of life. So medications for pain and suffering are totally still on the table. Treatment of symptoms within the context of the patient's goals. So again, if they don't want to be tubed, they don't want to be ventilated, then we're not going to do that. But it says you can ventilate but not tube me, things like that. We can make them comfortable, give them supplemental O2, again, if that's what they wish. So maximal efforts directed at compassionate symptom control. So again, with comfort care, pain control, positioning, assistance, things like that. So usually with these patients, transport's not usually the goal, but it may be appropriate for treatment of uncontrolled symptoms, and the patients may want us to take them. So with medical care, this involves advanced airway management for airway respirating conditions, but not for cardiac arrest. So if they're having a lot of trouble breathing, struggling to breathe, we can assist them with ventilations with either just with a BBM or again, depending on what they want, we can use an iGel. Even just OPA, NPA is not off the table for these patients because they're having trouble breathing. They want assistance with that. With these patients, well, for medical care, we can treat them for arrhythmias. We can use IV access to get medications for arrhythmias. And also we can transport for diagnosis and treatment. So this patient, maybe they're not that far along in their disease progression. So if something happens, they still want us to intervene, minus the chest compressions. So we can ventilate, but not do CPR. Again, oxygen, suctioning, manual treatment of the airway, medications for pain control, they're also on the table. Yeah, and just compassionate symptom control. So for resuscitation, that means they want everything on the menu. So full resus, advanced airways, interventions, mechanical ventilation, chest compressions, they're full code. So with that as well, at the line at the bottom, it says, if required care is not available at current location or setting, does the patient will be transported to alternate facility that can give care? So if you're doing a transport and no is checked off and they're like, we want you to IFT this patient, and they've checked off no, they don't want to transfer them out, then we should probably have a conversation with the care facility about that. So on the back of the form, like I said, make sure you actually have this on your copy as well. A lot of times they just photocopy the front, not the back. This is where the patient's supposed to sign to confirm their wishes of care. If it's not signed by the patient, it's not even worth the paper it's written on because anybody can just stamp the demographics, check off, and don't resuscitate and give you a piece of paper. Like, it doesn't make it legal at all. So either if it's not signed, you can get the patient to sign it. If they're like, just because they're palliative doesn't mean they can't talk, they can't write, things like that. So if you discuss with the patient prior to transport saying, hey, do you want to be resuscitated? And they say no, like, great, can you sign this document on the back? That's totally legit. If the nurse signs it, that still doesn't count. The patient has to sign a DNR to make it a legal DNR. And this is where we've had issues with this form where they're just getting a nurse checking off, do not resuscitate, here's your DNR. We have to get the patient to sign it. Also in the back, there may be more specific instructions for care. Like before, they may say, you can ventilate, but no tubes, stuff like that. So they may have more specifics on the back, or it may say, see patient chart. And if it does say that, we need a copy of that because obviously if we're transporting, we need to know what we can and can't do before we leave the facility. Make sure this is fully filled out before you leave, because the last thing you want to do is have them say it's a DNR. When you get to the next facility, they're like, we never signed that. And yeah, it saves a lot of trouble. If you're not sure, talk to the care facility. They should be up to speed with that. If they can't answer your questions, then you might need to make sure that stuff's taken care of before you transport. Because the last thing we want is someone becoming deceased en route and you being stuck on the side of the highway doing CPR where you never needed to, or vice versa, you don't do CPR and they're like, why didn't you resuscitate this patient? So make sure your documentation is all in order. So the letter of anticipated death, we're going full other way here, is this allows the patient to die at home without us having to call RCMP to investigate the death. Usually with letter of anticipated death, these patients, to get one of these letters, they have to be living with life-threatening illness, they're deteriorating, and death is imminent for these patients. Patient and or family may have expressed the desire to just die at home. They don't want to go to the hospital under any conditions. They are staying at home. The patient also has to have support systems. The patient can't be living by themselves because obviously that's not going to work out too well for them at end of life. So that if they're part of the palliative care program or their family, things like that, they can get one of these letters. The patient is signed of a Healthcare Directive form indicating they have chosen to not have CPR performed if they become deceased. Their physician has to sign this as well. So it is signed by their physician recognizing that the patient is in the state, they can die at home, that's their choice. So there's a lot of people involved. So the RCMP are notified, their doctor signs it off, the patient signs it off, all that good stuff there. So these patients who don't need to transfer, we still get called to these patients sometimes because when these patients are dying, and when the family's told how it's going to look like in an office by their physician, it looks one way, but when we get there, the family might be very distressed because their loved one might be struggling to breathe, things like that. And it's not a pleasant thing to see. So with that, we might be doing more support for the family as opposed to the patient. But if they have that letter of anticipated death and the patient becomes deceased while we're on scene, we don't need to resusc. We don't need to call RCMP. We can just say, do the sorry for your loss and give that emotional support to the family. But we really don't need to go any further than that. I personally have been in a couple calls like this where the patient does have letter of anticipated death and they just want us to. They just call us because they want to confirm they need someone to tell them that this person has died. They just can't bring themselves to tell themselves that. So they call us, we get there and they're like, can you check them? And we're like, I'm sorry, this patient's deceased. They just need someone to tell them to make it final. So, and for us, it's pretty much, we don't do too much for that. It's just emotional support for the family. We don't need to do anything for the patient. So reviewing goals of care is huge, right? Because then you see there's lots of documentation involved, what we can't do, what the patient may or may not want. It may be a very simple request. They just need help repositioning because they just can't, or it could be we're doing a bunch of other things. So like I mentioned before, we could also be assisting with administration of previously prescribed medications. Like I was saying before, if they're registered in the palliative care program, once all their paperwork is set up, hopefully it's done before you get there, you can access the home care charts, take a look at what they're taking, how they're supposed to be taking it, if they've been getting it at all. Some patients may even have pre-drawn medication syringes that we can access to give medications to these patients. So if this patient's needing help with pain control and they have their own pain control, doesn't matter your scope of work, you are able to give them their own medications. Where this kind of differs is that if we are needing to access our medications, so for example, if the patient needs morphine for pain control and you're a PCP, that is outside your scope of work. If you need to draw out of your pouch, you can't do that. You have to stay within your scope of work. If you're assisting the patient with their morphine, you're allowed to do that. But once you start dipping into your own supply, you need to call in another crew to do that. Another thing as well is we're going to look at medication administration a little differently with these patients because, so just going back to it, for example, like fentanyl, morphine, a lot of the meds we have, you can't give it if they're severely hypotensive, short of breath, things like that. With that, these patients, we can still give it. So it kind of omits those things. So it gives us a little bit more, I guess, wiggle room to give these patients pain meds. We don't have to check their blood pressure. And especially with blood pressure, like if you feel like you need to do vitals, great. But just keep in mind that if we're doing blood pressure and stuff, if these patients are really cacaxic, so they've got that muscle wasting that comes with end of life because they're not eating, their body's kind of done, we can actually cause a lot of damage to these patients by putting the blood pressure cuff on because you can cause a lot of bruising. We actually was teaching a few weeks ago where we had one paramedic saying that they actually caused a minor fracture in the patient's arm because they were just so frail and weak when they did a blood pressure. So again, we can give meds to these patients. We know where they're going. We don't necessarily need to do a full assessment on them. And like I said before, if you have any concerns about giving meds to these patients, you can always call Online Medical. So getting to the actual care map itself, so is the patient in a crisis situation? So due to the patient's condition changing, and a lot of times, again, some of these are just more emotional support where the patient is getting sicker and there's no illusion of where the patient's heading to because of their disease progress, but the family still calls for assistance or affirmation like, yeah, this is the disease process, they're not suffering, things like that. But a patient can still have crisis that they might need our help with. So such as impending airway obstruction. So if the patient is no longer able to maintain their own airway, they need suctioning, maybe some supplemental O2, we may be called for that. Massive hemorrhage as well. So if the patient has like a tumor or esophageal varices and they start bleeding out a lot, we will be called for that because the family may be told, yeah, there's the risk of this happening. You may see a lot of blood at end of life, but it's one thing to talk about. It's not a thing to see it. So we may get called for that. And seizures are pretty straightforward, right? So if the patient's having a seizure, if they've got brain mets or just some kind of other issues going on, we can get called for seizures. So if the answer is yes in that crisis situation, the care map there has got midazolam. We did add ketamine. We don't have ketamine right now because there's a severe medication shortage. So they pulled it off truck because they figured the facilities needed it more than we did. So we kind of lost it for now. But once it comes back, we'll be able to access it again for these patients. So with this for giving midazolam, we're basically giving it to ease suffering and increase comfort in these patients. And this is where we have to have them register in the program because if you have a patient we obviously give midazolam for seizures. We want to stop the seizures, but for patient care and comfort, normally for someone with airway issues, we don't give midazolam. That doesn't say that anywhere. But for these patients, we can. If they're bleeding out, we're going to make them comfortable end of life. Some patients that actually they know that's probably how they're going to go. Tammy Lee, the palliative care nurse that helped create our program, she's saying she had a patient that actually had a very large tumor that was basically eating away at her neck, and you could see all the structures inside her neck, and it was just a matter of time until the cancer wore away and she was going to bleed out through her throat. So if we get to stuff like that, we're not going to fix it. Like we know where they're going. So that patient she was talking about actually had a vial of midazolam taped above her bed on the wall. So that way, if it did actually start bleeding out, they could just load her up with midaz and put her to sleep so she wouldn't suffer drowning in blood, which is a terrible way to go. Other things that might be done if you have a patient that's having massive hemorrhage, family, if they're expecting it, family might be told to have dark sheets, dark towels, that way it doesn't soak into the sheets and look like a murder scene. So it can be traumatizing for both the patient and the caregivers. So that's just why we might be getting called. So we can give midazolam for that just to help reduce the pain and suffering of the patient at end of life. One thing I like to bring up, though, again, with like impending airway obstruction, is that if the patient is at end of life, we give midazolam. Can midazolam drop their blood pressure, stop their breathing? Absolutely. It's not your fault, though, if that happens. So if you have a patient that's bleeding out, we give midaz, and they become deceased after that med admin, that is 100% not on you. They're end of life. We're just helping reduce their suffering at that point. So can it happen? Yes. And at some point in their disease progression, they're going to get that last dose of medication. So don't put it on yourself if you give this patient midaz to make them comfortable and they become deceased after that. You just happen to give it as they were dying. It's not the other way around. So just something to keep in mind for yourself, just for your own mental health. It's got nothing to do with you. You just ease their suffering as they died. So in the care map here for midazolam, this is in the actual palliative care map. It does not correspond with the M07.1, which is the medication profile for midazolam. It's going to be different because we're using it for different reasons. So difference here for one is for midazolam, you have your subcutaneous dose in here as well. And it's 2.5 to 5, 2.5 at 5E, and you've got different repeats. And again, it says no max. So we're just going to keep giving them midaz until like we get their seizuring under control, we make them comfortable, things like that. Again, the only reason we don't give it is if we know they have bad reactions to it. So with this here, you may also notice that it's just got intranasal, subcutaneous, and intravenous. IM is not in this, and which is, again, a difference from M07.1. The reason we don't give it IM is that at end of life, these patients may have a lot of muscle wasting, so they're cachexic, and IM just may not be a very viable option. They may be very wasted away and just not have the muscle tone to accept an IM injection. So that's where we go with subcutaneous route as well. And again, difference with this one is we don't need to do vital signs before we give it. If they're bleeding to death, we give them a DAS. I don't care what their blood pressure is. We can just go ahead and make them comfortable. So if they're not having a crisis situation, are they having any pain? So a big thing with pain control is it's great to give meds, but look at non-pharmacological solutions as well. Maybe just patient positioning, just to alleviate discomfort. Talk with the family, like, has this been getting worse? Do some investigations. Don't just say, oh, you're having pain, here's your meds. Because sometimes it may be that their bed sucks and they're sleeping on a terrible bed because they want to be in the living room, or they're living on their couch because they want to be in the living room with their family, things like that. And so, of course, they're having back pain, which isn't helping their situation. That's something we could follow up with the palliative care team because they're in the program of maybe getting them a better bed, like a hospital bed, which they can do. I don't know how long it takes, but that is a thing that the program can do. And then that way they can be more comfortable, and it's more of a long-term solution to the problem, not just bumping with meds and say, have a good day, right? So yes, we can still go in pain control, but we can also look at how do we help reduce pain further on. Another thing as well is you still want to do a full assessment for pain, right? How is this different? Why are we being called today? And be nice about it. Don't be like, oh, why'd you call us today? He's in pain all the time. Why is it different for us now? So we want to know, okay, when did it get bad enough that you decided EMS was involved? Like, what pain meds are they on? Why is it not working? Because again, this is all stuff that needs to be followed up with the palliative care team. Because if the patient's meds are not working for them anymore, they need to know that so they can change doses, change routes. Like they might go from oral to subcutaneous or to a like a fentanyl patch, something like that. But they don't know if we don't let them know. So they need to follow up with the palliative care nurse in regards to possible further pain control. The other thing we have to remember is that when patients have pain, we have to determine, is this part of their palliative care or is this a completely different pain? Because it is totally possible for someone with cancer to have an MI. So if they're on the palliative care team, we still want to assess our patient. If they're having like that crushing chest pain and they're like, well, usually it's this hip that's always hurting, we need to investigate that. We don't just write off as, well, they're palliative, here's your pain control. And we want to make sure they're not having any kind of new types of pain crisis. So when it comes to giving medications for pain, so on here again, it's got ketamine. We don't have access to that right now. We can use fentanyl or morphine, but like I was saying before, if you're going to give morphine and it's the patient's morphine, it doesn't matter your scope. You can access it as long as you reference their home care chart. If you're needing to draw out your pouch, you have to respect your scope of work. So for PCPs, that means just giving fentanyl, and like it says, all routes, which is a nice change. And for morphine, you need to be an ICP or above to give morphine to these patients out of your pouch. So again, these are going to be a little different than the medication profiles that are in the shared health care maps. So for fentanyl, again, intranasal, subcutaneous, IV. So it's 2 mics per kilogram, no max, or 1 to 2 microgram kilograms per max. So, you can modify your dosages for IV if you choose to. So with this here, again, we can repeat it every 5 to 10 minutes, no max, very different than what we would normally give according to the care maps. The other thing as well, in med profile M03.2 for fentanyl, it states that the patient's not to be given fentanyl if they have decreased LOC, they're hypotensive, hypoventilating. That's off the table for these patients. That could be their daily norm. So we're not going to take that into consideration. Again, you may not even do a blood pressure. If you want to check distal perfusion, do a SAT, absolutely. But we don't need to have those definitive. We're not going to judge whether we give this or not based on their vital signs. And again, is it possible the patient becomes deceased after you give them fentanyl? Possibly, but is that where their disease progress is going? So, do a full assessment if you're not sure. Nothing wrong with that at all. And again, for fentanyl here, IM is not listed because that's not really preferred route for palliative care. If they still have good muscle tone, they're not that far along in the disease progression, absolutely still use it. But if you're going to give it IM, you have to use it by the care map then, and hypotension things might apply. So we may not be able to give it that route as well. Another big thing with giving fentanyl, it came as a rule a little while ago that if you're going to give intranasal fentanyl, you have to have IV access prior to giving it. For palliative care patients, you don't. You don't need to have an IV first. You can just go ahead and give it intranasally. Again, if they're having a pain crisis, we really need to help them out with that, and getting IV may not always be viable. And like I said, hypotension is not a contraindication to giving fentanyl for this care map. So for morphine here, we are trying to match what the patient has been prescribed. So it could be that they're taking orally, it's not working for them anymore for whatever reasons, because as you get older, gastric motility decreases, patient may not be able to swallow anymore, and they just can't give them their oral pain meds. So we might have to step in and give them either subcutaneous or intravenous. Morphine. So like I was saying here, as it shows in the care map here, if you're drawing from your pouch, you need to be an ICP. So if you're a 2-PCP crew, and fentanyl's like not working for you because it's got a shorter half-life, you could either call for a second truck, which we don't know if one will be available. So you might have to have a transport conversation with them about, do we have to transport this patient for pain control now? So one thing to keep in mind, if we're trying to match their dose as best we can, we are not to match their long-term dose, but what their breakthrough dosing is. So if you talk to the family, you should be aware of that if the patient's already got this. The long-term dose is going to be much higher than the breakthrough. So if we're going to go along with what they're being given, like orally, we're going to use their breakthrough dosing, not their daily dose. So because some of the times, like I said, you might be called because this patient's on an oral medication and we need to give it now, we need to give it subcutaneously or IV, we are going to have to do some math. Yay, everybody loves doing math on a very sick and pain patient. So to do that, we're going to do some calculations here. So for example, if you have a patient that's taking 2 milligrams of oral hydromorph or dilaudid, we would multiply this number by 2.5, and that would give us 5 milligrams of morphine IV subcutaneously. So if the patient's on oral codeine at 30 milligrams per breakthrough dose, we multiply that number by 0.05, and we give 1.5 milligrams IV or subcutaneously. So that's just how we can calculate what we're going to be giving for morphine. If you're giving the morphine via IV route, you still want to dilute it as per the norm. So we want to make sure we put that dilute it with saline. Do not use the preloaded syringes. That's been put up by pharmacy companies to dilute it. But the other thing to keep in mind is that if you're giving it subcutaneously, you do not need to dilute your morphine. If you're giving Gravol, you don't need to dilute your Gravol. You don't need to dilute any meds if you're giving it subcutaneous, because we want a more concentrated dose so we can give more. Because realistically, you can only give 2 mLs of a med through a subcut line. I do have a video in the YouTube channel about how to do subcut lines, so you can watch it there. I'm not going to go over that today. But if you're going to give meds, don't dilute it. We want to give as much concentration, because if we can give 2 mLs of morphine and it's 10 milligrams per ml, we can give up to 20 milligrams at a time through a subcut line, versus if we dilute it, it's going to take forever. So if you're going to give it subcut, especially, don't dilute your meds. So if the patient's not having a pain crisis, are they having any respiratory distress? So similar to pain, like let's try non-pharmaceutical things first. So like, can we help them sit up? Do we need to get some more airflow? Do they need maybe a little bit of supplemental O2? Again, this is everybody's favorite part of these patients was when we were talking about giving a fan at the end of the bed, so that way they can get that movement of air over their lips, so they can feel like they're getting some air movement, and that can actually reduce shortness of breath. So we could try non-pharmacological approaches first as well. But if they are having shortness of breath, we want to make sure we still do a full assessment, listen to their lungs. Like, again, just because they're palliative doesn't mean we're not going to do anything for them. So if they're end of life and they are having pneumonia, they have a pneumonia or something like that, because a lot of these patients can be immunocompromised, we would want to take them to the hospital, get antibiotic therapy, because that's comfort care, because they're uncomfortable because they're drowning in their own fluids. Can we do something about that? Possibly at the hospital. So that would, again, would be a conversation with the patient and their proxy if the patient wants transported. If they're having anaphylactic reaction, we're going to treat it as per. If they're having asthma attack, we're going to treat it as per, like we normally would for anybody else. So make sure you do a full assessment. We can give these patients supplemental O2 as well. Maybe they just need topped up. Some patients, especially like patients with lung cancer and stage COPD, they might be on home O2. So that could be just okay, well, from now on, you need to up your home O2, or maybe we need to call the palliative care team and say, hey, this patient needs home O2. So that kind of puts us in a bad spot, though, because if we are giving these patients supplemental oxygen and then then we have to leave. So we need to kind of have something set up. So if we get them through their crisis, great, but we need to have some follow-up with the palliative care team in regards to that. So for here, it's got an interesting thing where it says if there's dyspnea or respiratory stress, we can give supplemental to fentanyl or morphine. So for years, we've been taught, don't give people with respiratory issues, don't give them opiates or opioids, because that's going to slow down the respiratory rate and cause further problems. So for this one, for palliative care, again, they have to register in the program, because we're going to give opioids or opiates to help them with their breathing, because basically we're trying to make them more comfortable and relax them. And so that's what we're looking for, because again, it's end of life care. We want to make sure these patients aren't suffering. And like I stated before, the difference with this care map as well, if we're going to give morphine or fentanyl, you don't have to have specific vital signs beforehand because these patients' baseline may be hypotensive all the time. Their decreased LC might be their norm. So that's not going to be a factor. We want to make sure these patients are comfortable. I'm not saying just go ahead and give these medications liberally, but it does give us a lot more space to make that clinical decision whether it's going to be beneficial for the patient or not based just on numbers, but actually based on what the patient needs at that time. So is the patient suffering from nausea or vomiting? So that's always a fun one. If the answer is yes, it maybe needs some intervention. So a big one is, again, like everything else, try non-pharmacological approaches first. If the patient's really stressed, there's a lot of stimulus affecting them, making them nauseous. So for example, they're in the living room on their bed and their significant other's cooking up lots of food, but they're at that point of their life where they don't want food. They're just not able to, it makes them nauseous just to smell it or see it or even have it put in front of them. We can get that stimulus out of there as well. So we could look at that, just the environment they're in. If they're really nauseous, you could try the good old alcohol swab underneath the nose trick, and that can help release nausea as well, while we're setting up for other interventions if required. So it could be that they're vomiting a lot because they don't want to eat. They're at end of life as well. So if family is like, "Oh, you need to eat," he's not eating, that can be a part of the disease process, especially at end of life. So that's something we may need to talk with the family about, saying you need to stop force feeding food into this person because they're just vomiting it all up. Their body's rejecting it. Their body's kind of done. It doesn't want food anymore. So that can be something we can resolve without having to get medications involved. Other things as well is to keep in mind if that patients are taking high doses of opioids or opiates, they may develop constipation, which can cause a lot of nausea in the patient. So we're going to actually assess our patient and we're going to check their abdomen, see if it's distended. We're going to ask about their bowel habits. We're going to see, their ins and outs. Are they taking in fluids, foods? Are they putting any out? Obviously, if they're not eating and drinking, if they have like no bowel movements, very little urine output, that's not to be unexpected, right? Nothing's going in, nothing is going out. That's understandable. If they're eating full meals and everything and nothing's coming out of them, then that could be a concern. So if they are on high doses of their own pain control, they should be on laxatives, especially with taking opioids because that causes constipation. If they're not, that should be followed up with their palliative care team. It should really be prescribed together at the same time. So with that as well, when it comes to output, just to throw a side note in there, we want to check we're always concerned about UTIs in patients that are immunocompromised. So if they are peeing and they've got it's very strong odor, strange color, blood, any chunks in it, things like that, all that fun things. We could also look at transporting this patient for treatment of UTI because again, it's an infection that can be treated and that's a comfort care issue. So medication that can be used to control patient nausea. Overall, Gravol is not found effective in these patients, so that's why it's not in the care map. So we're either going to go with Maxaran or ondansetron. So when it comes to Maxaran, it's classified as an antiemetic agent that blocks dopamine receptors. At higher doses, it blocks serotonin receptors in the chemoreceptor trigger zone of the central nervous system. So Gravol is basically antihistamine. So as my spiel there just says, this is a lot more specific to what's going on. So with metoclopramide or Maxaran, it actually causes enhanced gastric motility and accelerates gastric emptying. So that helps speed up the process to help reduce nausea, things like that. That can help relieve, if they've got some kind of, it's taking a while for their body to process food, that can make you nauseous, not feel good. This can help speed up that process. So that helps get rid of that nausea and vomiting. So again, before you give this, you should have that conversation about ins and outs. You want to do an abdominal check and see if they're obstructed, because if we use Maxaran, it's actually very dangerous if they have a bowel obstruction. Because again, if it increases that gastric motility, and we use it for someone that has a bowel obstruction, it can cause damage to the organs themselves because they're trying to move a brick, right? So if it's just stuck in there, it's not going to work for them. So things that can help you be suspicious that they may have a bowel obstruction is very distended, very uncomfortable abdomen. They haven't had any bowel movements, even though they got intake, nothing's coming out. If they are still having bowel movements where it's very thin and liquidy, that's not really an indicator that they're not having a bowel obstruction because that could just be overspill of mucus from the actual obstruction. The big concern we have with this is that if they're no longer passing gas, if the patient is unable to pass gas, they're very bloated and gassy, but it's not going anywhere, that's a really good indicator they have a bowel obstruction. So they should probably go to the hospital and get that dealt with. Because again, it's comfort care, but that doesn't mean no care. So, if you got a chunk of feces stuck in your bowels, that's not comfortable. So we can deal with that at the hospital. Other thing as well is when it gets really severe, I don't know if anybody's had this call. I've had like maybe 2 in my career where it's not a pretty thing, is if they're vomiting fecal matter because of their bowel obstruction. Like, yes, that's taken to the hospital, because the family's like, well, they don't want to go no matter what. It's like, you might want to make change your mind on this one. So again, this is a discussion to have about why we need to go to the hospital with these patients, because that's just not a great way to go. Another medication here is ondansetron. It's an antiemetic that is classified as a selective 5-HT3 receptor antagonist. So this blocks serotonin, both peripherally on vagal nerve terminals and centrally in the chemoreceptor trigger zone in the brain, resulting in a large antiemetic effect. So this is affecting it at a brain level here. So this is actually the medication of choice for patients that are on chemotherapy. So if your patients at palliative chemo, I've had a couple patients that are getting chemo just for pain control to try and keep the swelling of the Mets down enough so they can tolerate being alive, honestly. This would be the go-to. If you're worried about bowel obstruction, you can use this as well, because this doesn't cause that gastric motility like Maxran does. So this is kind of really, for palliative care, this is kind of the ideal med. When we first introduced this care map, one thing we decided was, because we want to make it accessible to everybody, if you look at your regular care map for or medication profile for ondansetron, it is an ICP scope medication because it can cause QT prolongation. But for palliative care patients, that's not a huge concern. We're not really worried about firing them into torsades. So for palliative care, we made it PCP scope. So there's a bit of a change of scope of work in that one as well. Again, this is why they have to be registered in the program, so we know who we're dealing with. But for ondansetron, for palliative care, PCPs can give it. For anybody that's not in the palliative care program, it is an ICP scope medication. So the next thing we have here with nausea, vomiting, you might have all of these, be dealing with all these things. So keep that in mind. You may have multiple things going on here, because pain, discomfort can cause nausea, vomiting. So, if you deal with the pain, nausea, vomiting might decrease. You might have a little bit of everything as well. So just keep that in mind. So when it comes to airway secretions, at the end of life, patients may have secretions in their lower airway. This can be a result of fluid accumulation in the patient's vocal cords, and it's nothing threatening, life-threatening. It's not they're drowning in saliva, anything like that. Normally, we would just swallow it, but these patients may not be able to do that anymore because of their decreased LOC, just inability to swallow. Sometimes it's called the death rattle, which some of the palliative care nurses don't really like. But basically, it's just there's a little bit of fluid sitting on the vocal cords. It sounds terrible, but it's basically just really different causes of snoring. So tell the patient's family what's going on. Suctioning is not going to fix this because it's further down than we can go. We can't go into the trachea and suction where this is happening. So we could look at patient positioning, being very gentle with them, because sometimes, I hate to say it, repositioning patients can cause them to become deceased, because if they're that frail and that weak, rolling them onto their side to get rid of that snoring may be enough to end their life. And that's just the reality of these patients. So that's a conversation you need to have with the family. Just make sure they're aware that the patient's not choking. They're not in any immediate danger. Again, it's just the end of life stage that they're in right now. And for therapy for this, we used to have scopolamine patches because of its anticholinergic properties, would help dry up secretions. But honestly, the company that makes scopolamine patches doesn't make them anymore. They kind of went out of business because of COVID, because originally patches were made for people to wear on cruises to help with nausea and seasickness. But there was a lot of cruises going on during COVID, so they stopped making them. So we're looking for another alternative right now. And if it's really causing stress with them, we could call online medical and say, what do you want to suggest? And again, I wouldn't recommend transporting these patients if they're that close to end of life, because again, we don't want to have a deceased patient in the back of our ambulance, because honestly, if you have a patient that dies, even though they have a letter of anticipated death at home, if they die in the back of your ambulance on the road, they're not at home. That letter does not apply. We have to treat it like a regular death and call RCMP and have it investigated. Just throw that in there. So positioning might just be all you need. Maybe just prop up another pillow underneath their head and just help with them with their assisted respirations and talk with the family. So does the patient have anxiety or agitation? So we're going to determine if this is an issue, if it's new, if it's different, because if they've got dementia versus delirium can come on a bit quicker than dementia. So ask that, like, what's changed in the patient. Has this had a sudden onset? Has there been a slow onset? Is this their norm? Like, what's their baseline? So we want to ask that as well. Because we're always concerned that if patients, again, UTIs can cause a difference in LOC, it can make them combative, anxious, stuff like that. So if that's the cause of it, if we're suspecting a UTI or some kind of infection process that's making them act abnormal, we can deal with that at the hospital. We might have to discuss transport for that, versus it's just their disease progress and the family they honestly can't handle the patient anymore. So some things we can do when we're talking to the patient is we can make the environment more appropriate for them. So things such as reducing noise, like if they've got their TV cranked up to 100, turn the TV down so they can actually hear you. Not having everybody in the room, because it can be very distracting and overwhelming, and that can irritate the patient even more. And sometimes that's an issue as well, is just the patients are on them, the family members are on the patient all the time, and they're just frustrated and stressed, and they're just tired of being told things like that. So try to make it a very reasonable environment. The other thing as well is sometimes with these patients, it's best if only one paramedic talks to the patient, not both, because if one's on one side, one's on the other, we're both firing questions at this person that's already mildly confused and very anxious, that's just going to stress them out, make them more agitated. So I always find on these calls, the patient usually prefers one medic over the other. So whoever gets along better with the patient, they should talk to the patient. The other paramedic can be out in the hallway talking with the family, getting history, things like that. And that way it makes less chaos in the room for them. Other things to think about for helping reduce anxiety, agitation, like if they need glasses, if they're supposed to have a hearing aid, hook them up with all that stuff. Because if we're trying to talk to them and they can't hear us, it's not gonna help the situation. Maybe reducing lighting, like not make it so bright, again, just less input to overwhelm the patient. So other things you want to look at as well is check their medication records. Sometimes a change in medication can cause increased anxiety or agitation, and just cause a change in the patient's temperament. So ask the family or the caregivers, like, did they start this med? Did you notice a change as soon as they start taking this med? Because again, that's something we need to follow up with their palliative care team, because if the med's obviously not making their life any better, it may not be a good choice for them to be on. So again, dementia, delirium, we need to take a look at, is it either one of those, or is this medication based, or do they have fever? Is it from an infection? So we want to try and rule all those things out there. If we're worried about opioid toxicity, especially like I was saying with medication, if they've suddenly just upped their dose for pain meds and now they've just had too much of an opiate or opioid, they can get toxicities. So they get metabolite buildup in the bloodstream. So with that, we just need to help them flush it out. Again, maybe talk to the family about not giving so many breakthroughs, like, because every time the patient's like, that kind of sore, and then they just fire morphine in them, it may not always best, they're doing what they best they can, but it may not be the best solution. So we could have that conversation with them. But to get the actual metabolites from opioid toxicity, we just need to get fluids in. So that could be oral, like if the patient's still completely, conscious, able to swallow, give them water. They can just drink it and it'll naturally work itself out. If it's really bad, like they're not able to swallow appropriately, worried about choking, we could look at doing IV fit therapy while we're there. But realistically, oral hydration would be the best route, because that's more long-term than us starting an IV. If you do start an IV on scene, you do not leave it in place. Once we leave, you take your IV out though. So just keep that in mind as well. But it should be followed up with home care and or the patient's palliative care team. So with that, if they have anxiety or agitation, we can give them midazolam for that as per the medication dosages in the care map here. So the thing to keep in mind is that versus like when we talk about crisis situation where it's like, yeah, you can just give them as much midaz as well. Like for these ones, because we're just trying to reduce their anxiety agitation, I wouldn't fault you for taking a set of vitals for this if you can, but try to get an idea where they're at. And for this one, it's not like give as much as you can to make them comfortable. We're going to be a little bit more controlled with the amount of midaz, because again, we just want to make the patient comfortable, reduce that stress, reduce anxiety and agitation, and then take it from there. We're not just making them comfortable end of life. So there's a little bit of difference of use with midazolam, even though the dosing is the same in the care map. Another thing to keep in mind is, where's the family at? Are they able to handle this patient anymore? Because there's been a few calls where they're not calling for the patient, they're calling for them. Like with sundowning patients, when they can become very difficult in the evening. The family just can't handle it. We had one patient where she was kind of delirious. She had dementia, and she kept trying to get out of bed, and she kept falling out of the bed on a regular basis. And the family was so stressed out all the time, because she would just constantly keep getting out of bed and falling down, hurting herself. She had like 6 falls in one evening. And they just couldn't do anymore because they were saying they hadn't had a good night's sleep in 3 nights because they'd always fall asleep and hear a thud as she'd fall down and hit her head on the ground. So they called us to take her somewhere else. So they didn't, because they just couldn't care. So it wasn't really a failure to cope. It was a failure to cope for the caregiver, like caregiver fatigue. So we might get called for that. It may not actually be for the patient with the agitation, anxiety. So something to think about as well. And a conversation with that, if they're on palliative care, they can look at maybe getting respite work in so that they can take a day off every now and again. But don't be surprised if you get called for these patients and it's because the caregivers just can't look after the patient anymore. It's too much. And I think that's reasonable to understand with the family. But if we just want to make them comfortable, you can give them a DAS if you're going to go down that route. Another option as well is we do have our agitated patient care map. So the patients become very violent, disruptive, trying to assault you, other caregivers. You can access that one separately because again, that's not palliative care issue. If they are in delirium and they're looking at injuring everybody and themselves, then we can access the agitated patient protocol care map and use Haldol, things like Haldol and midazolam to sedate the patient. Then we might look at transport after. And I'm not going to lie, some of these patients, just because they're just so confused and angry, they may become violent. So I'm not going to say don't take the thought of calling your RNP out of the loop here either. Usually it doesn't get that bad, but I've seen there's some pretty rowdy end of life patients just because they're meds and they just can't think clearly and they're just aggressive. So, personal safety as well. So at the end here, it says if goals of care do not include transport, support unseen until issues resolved. So part of this was recognizing that we might have a longer unseen time than we would for a normal emergency call. That is fine. There was some issues that were brought up from the powers that be about, well, you can't just have a paramedic sit there unseen for 4 hours. It's like, well, why not? If you have a patient that's being extricated out of a vehicle and it's very difficult, they're not going to say, well, it's taking too long to get this guy out of a car, go somewhere else. Like, we're going to stick around. And this would be the same thing. The other thing as well is realistically, we transport these patients, we're probably going to be sending in the hallway of a hospital for quite some time because these patients are really given a low priority when we get to the ER, just to be realistic with it. So, spend 2 hours on scene with this palliative care patient versus 6 hours in the hallway, it makes more sense. And overall, in studies from other provinces that have done this as well, it's always resulted in less wait times, more trucks available sooner by having that longer on scene time versus transport time, going to the hospital, stand around time, things like that. So there's nothing wrong with spending a couple hours on scene with these patients. So take your time. Again, we're going to discuss what's best for the patient. What can we do? Sometimes we get there and the family's like, you need to take this guy to the hospital. Have a conversation. And again, transport's never off the table. But if their goals of care do not include transport, we can help them stay at home and be comfortable. And again, that might be given pain control, midazolam, things like that. If the patient is to be left at home, so if we did start an IV line for fluid therapy, once you're done, make sure you take it out. You can leave if you start a subcut line, you can leave it in the patient for after you leave, as long as the family and the caregivers are aware of what it's used for and how to use it. If they have no idea what it's used for, they have no reason to have it. All the meds you have are oral, they don't have anything they need to inject or give subcutaneously, then take it out. You don't leave it in. They're good for about a week, but if they're not going to use it at all, there's really no point leaving it in place. So again, that's a conversation to have with the family. So if we do leave and we don't take the patient with us, ensure to document the patient home care chart. In the progress notes, you have to document your ambulance number, you sign your name, your license number, and what you did when you got up there, what you did for the patient, things like that. Oh, sorry, I pushed the button there. So with that, we want to put down what we did, things like that. So let's say the patient had a subcut line, it looked kind of infected, the family didn't want to use it anymore, so they call us, we go on the other side of the arm, and we give one on the other arm, and that's all we did. You just want to write that into your progress notes in the home care chart, so that way they know that this site's infected, don't use it, and we started a new one, so they don't need to start a new one themselves. Other things as well we want to document in our documentation, if we're not going to transport, is finish your PCR on scene, and then everybody signs it. You take out your hospital copy and you would leave that in the home care chart. So that way when home care or the palliative care nurse comes to visit, they'll be able to read your PCR as well. If you're transporting, you try, based on the patient condition, try to write in the home care chart at least the ambulance number, your name, your license number, and which hospital you transported to. So that way, if they show up, home care service, like, where's our patient? Why is no one here? They can just say, oh, the ambulance took him to such and such a hospital. So make sure that's documented if you have time, unless they're in like severe crisis, of course. ensure, like I mentioned at the beginning, make sure you put your patient's SPP number on your PCR so it's easily identifiable, especially for quality assurance purposes. Like, you're just giving this guy tons of morphine. What's up with that? It's like, well, they're palliative care. That would make sense. So please make sure to put your SPP number on your PCR. Once you get back to station, and we did a roadshow where we visited different stations quite a few months ago, but this was brought up where we would like you to fax a copy of your PCR to the palliative care team. The fax number is embedded into the care map, so it's accessible there. But we had some issues with faxing, so do the best you can. When you fax it, make sure it's long distance, dial 1204, and the number, I think in the care map, it just says 204. So, if you're up in Asher and Pine Falls, make sure you put a 1 in front so you're faxing it to them properly. And it goes into an electronic file. It doesn't actually print out on anybody's fax machine. It just goes into an electronic fax folder. So if you could do that, that'd be great, because if palliative care shows up on Monday and they've got 6 PCRs from Mr. Smith saying EMS had to keep going there every 4 hours for pain control, they're probably going to prioritize that patient to either talk to, phone, or actually go check on, because if we're there on a regular, they need to follow up on that. And they don't know if they don't know if we don't tell them. So another new care map just to throw in there, this kind of came up after the fact, was transport for direct admission to palliative care. So near end of life, some patients will have goals of care that include transfer to a bed in a dedicated palliative care unit or local facility. So within the IRHA, we do not have specific hospitals for this, but the palliative care physician may say if patient's condition gets to this, they are to be taken to this hospital because the family just can't. They don't have the resources to look after the family. So usually these plans for admission, they should be coordinated by a member of the palliative care team and their palliative care physician, or they're just their regular GP to go to a specific facility. Often there is a collaboration between the patient's personal physician and palliative care to try and figure out what's best for the patient. Should they stay at home? Should they go? Because again, they're palliative, and at some point, like I was saying before, the family is just like, you know what, it's too much. I can't do this anymore. We need to figure out something else for arrangements here, either bring in home care or find somewhere to admit them. So this care map here was created so we could be able to transport these patients to those facilities if needed for end of life. So indications for this, so primary response where the following conditions are met. So the patients register with any regional palliative care program. So this one here, like I was saying before, because we're in the Interlake, we have people from other zones come here, other health authorities. So if they're like from the North, West, Winnipeg, Brandon, whatever, if they decide to want to spend their end of life at a cabin, but they do have this directive by their physician saying, okay, if they get really bad and the family can't handle it, you're to take them to Riverview in Winnipeg, we can do that. And they don't have to just be registered within the IRHA for that to take place. The patient has an admission to a palliative care unit or other healthcare facility arranged by a member of the palliative care program or a physician. So that could be admission to a palliative care unit or other healthcare facility, and that's prearranged. So that could be those ones where it's like the ER knows you're coming, they're expecting you, you can go transport. Our doctors talk to the ER doctor. When paramedics are advised that a palliative care patient has an admission booked to a specific facility, paramedics will transport the patient to the facility as directed. Some facilities may require you go to the ER first. So again, if they're like, yeah, they've got to, because a lot of our hospitals have palliative care rooms, but just because of how things are in healthcare, those rooms might just be used for regular patients until it comes up as a needed room for palliative care. So they may ask you to go to the ER first until they can open up that bed for your patient. And then we just stick around with their patient until they get admitted. If the patient or caregiver is the initial source of information that an admission has been arranged, we should, tactfully attempt to confirm the patient is like, okay, sure, whatever, I've got to go to this hospital, right? We should have the paperwork there. If it's just them verbally telling us, that's not good enough, because we've all had it where like, I want to go to HSC. It's like, that's nice, but doesn't mean we're going to take you. So we should try and have that conversation. And it's more so because it's end of life, people are stressed, things like that. So we should have a conversation with them, but we need to have some kind of paperwork to go with it. Or we can contact their palliative care physician and have a conversation with them if the family's not able to have that conversation with us. Another one as well, the destination within 60 minutes of patient's point of origin. So, so if you're up in Gimli at their cabin and the patient's palliative care to be taken to Brandon, that's not reality. So we're not going to drive them all the way to Brandon, or if they want to go to Thunder Bay, like that's not going to happen. So We're going to go to if that's the case, we're probably going to go to the closest ED and then take it from there and find some other way to transport the patients. We're not going to go on transport this patient for 3 hours because they want to go to a specific hospital. And if it is an issue, we can always call online medical and get direction on that too. Another thing to keep in mind if that patient is confirmed to be admitted to a facility, if their facility's on redirect or anything like that, we can still go to that facility because this has all been prearranged. If you radio in and they're like, we're on diversion, say this patient has special admission, they're being pre-approved to come to your facility, we can notify them over the radio. And again, you can always call online medical if you start having issues with that. Reasons we don't use this care map is obviously if it's an IFT, if we're in the hospital, all this should be taken care of before we transport. We shouldn't be making phone calls for a patient that's in hospital to take them to another. If a patient's going from say like Beausier Hospital to a review, we just do that like a regular transport. We want to definitely get all our paperwork, like I mentioned before, in place. So make sure you have a copy of their DNR signed, both sides, care directives, all that stuff before we transport. Because again, if they're at end of life, the last thing you want to do is be stuck on Osborne, downtown Winnipeg, with a patient that just became deceased in the back of our ambulance. That's not going to be great for us if we don't have documentation with that. So with that, make sure you have all your paperwork in place as well. And that's all I've got for today. So thank you for listening in on palliative care within the IRHA. Any questions at all? All right, I'm not hearing any, so you're very welcome. So with that, I'm going to conclude, and this will be uploaded to the YouTube channel.